thank you again for your time this afternoon. I hope that this second webinar will be very, very valuable for you. Thank you again for your feedback on the first webinar. That helps us make this one better. So what do I want to accomplish in the next 45, 50 minutes before we get to the Q&A? We're going to do a little bit of review to look at what we talked about last week. Remember, we've got some big changes coming up. We're moving to this new world of MIPS and alternate payment models where the government is trying to shift away from fee-for-service towards a more value-based reimbursement world where they're measuring quality of care delivered, where they're measuring resource use, and those measurements are risk adjusted. That means our diagnosis coding is going to be much more important in the future than it ever has been before. So I'm going to go through a bit of review just to get everybody's head in the right spot as we start our discussion today as far as how do I really operationalize this in my practice. And then we want to be able to answer the question that says, well, what is the target? What is the goal for my HCC coding? What is our objective? How will I know if we're doing a good job? How will I know when we've done enough? And part of that, in order to do that, you have to know how you're doing today. So we're going to talk a little bit about that, how practices are doing today, share some of the survey results, the poll results from last week, so that we can begin to formulate a plan for moving forward. How do I operationalize this in my practice? The good news is we do have some clients who have already done this. They're either a part of an ACO or they've got risk-adjusted contracts with commercial carriers today. We can show you how they're leveraging tools in order to make that process easy for both their clinical staff and their revenue cycle staff. So we'll try to go through some very specific, very practical examples to help you. As I mentioned before, we'll have the question and answers at the end. So feel free to ask questions as we go. Shelley's going to try to answer as many of those as she can, but there are some that we typically get over and over and over again, and we know if you're asking them, chances are there's somebody else on the call who's got that same question. So we'll try to handle as many of those that are broadly applicable at the end as well. Okay, so as by way of review, remember what's happening. Remember what the government is trying to do through these new programs. They are trying to shift risk off of the payers, off of the government, onto patients and onto providers. And that is to accomplish the triple aim of healthcare. Better healthcare for lower cost and better patient experiences, right? That is a lofty goal. That is something that is very, very difficult to do. And what we've already seen parts of this through the Affordable Care Act, through some of the other programs that we've had to participate in recently with meaningful use and PQRS and value-based modifier. On the patient side, we see this in our own health plan every year. You probably see it too. Higher premiums, higher deductibles. That impacts us as consumers. It also impacts us as practices. Trying to collect from patients is obviously a significant challenge for many of our clients. And on the provider side, we see that through the quality measures, through the resource use measures that are coming in MIPS. The government wants to pay for value. And in order to do that in an equitable way, those measurements are risk adjusted, meaning the sicker your patient population, the lower your quality targets are, the lower your resource use targets are. And that's one of the reasons why it's so important to get risk-adjusted coding done correctly in your practice. And that means we have two big changes coming with how we do diagnosis coding. You remember this? For 35 years, we have coded with CPT codes, or how the physician practice gets paid. You have to have a diagnosis code that makes it medically necessary. That was true for 34 years in ICD-9. It's been true for the past 9 months in ICD-10. And if you make a mistake, a claim gets denied, but it's usually corrected, resubmitted, and paid. It's a 30-day cycle, right? The changes coming mean our diagnosis coding is going to be much, much more important in the future. Change number one is when Medicare and the commercial carriers begin to require additional specificity in order to get your fee-for-service claim paid, that ICD-10 grace period expires October 1st, 2016. Right, that's change number one. We don't have time to go into all of the details of that today. Most of you are doing a very, very good job with that. The national average for unspecified code use rate is over 30%. For our White Plume clients, it's closer to 10%. We're doing 3 times better than the national average, and that's something worth celebrating. But we also want to help make sure that you're prepared for the next big change that's coming. And MIPS begins right now on January 1st, 2017. And what that means is our diagnosis codes are used for risk adjustment under MIPS. We're going to live with those codes for 2 years. It'll impact this year's reimbursement for fee-for-service, next year's HCC scores, and then 2 years out, our MIPS scores start to impact your negative or positive adjustment under MIPS. So your diagnosis coding becomes much, much more important. And you remember last week we looked at 3 examples. 3 identical patients, all having total knee replacements. But what you code makes a difference in how sick Medicare and the other commercial payers think your patients are. Most people are not doing this very well yet. Right? We see less than 20% of the population out there say that they're actually doing a good job of coding all of these comorbidities today. And the reason why is because it hasn't mattered yet. Under our current fee-for-service model, that claim gets paid the exact same way, the exact same dollar amount, regardless of what your diagnosis coding looks like. But the 2 changes that we have coming are obviously going to impact how your fee-for-service claims are paid and how your HCC coding is done. Because the patient on the far right looks more than twice as sick as the patient on the far left. And this is the adjustment that Medicare would make to a Medicare Advantage carrier for that patient's capitated reimbursement for the next 12 months. That makes a big, big difference on how we code. Okay? That's why that's so important. That's why we need to be focused on it. So a lot of times people want to ask the question, so, well, how good do I need to be? I know this is graded against my peers. I know I have to outrun the bear, but how well do we have to do? And what I would tell you is the target is not necessarily a number. I can't tell you if you are able to code to this level average patient acuity, you'll be okay. Because you are going to be measured against your peers, and that number will move over time. The real goal should be to make sure that you accurately reflect what your patients look like, so that the government, so that the payers realize that your patients are as sick as you know that they already are. And that's important for several reasons. Number one, making sure that you have accurate targets set as we transition from this fee-for-service world to a value-based reimbursement world. Number two, making sure that the cost and quality data that's published on the Physicians Compare website is accurate and accurately reflects the high level of patient care delivered by your physicians. We know your doctors do an excellent job, and we certainly wouldn't want to underreport their quality or overreport their cost just because we haven't done a good job of reflecting patient acuity. We talked already about the quality and resource use measurements under MIPS, making sure that those are benchmarked correctly. But it's not just Medicare who's moving into this world. Remember, the commercial carriers are wanting to follow suit. Blue Cross, Aetna, and United, some of you are already seeing these types of risk-adjusted contracts, but we expect that that will be in the future for the rest of you very, very soon. And then the last piece of why this is important it's important to have good quality data on your side for your negotiations with your other payers going forward. They are looking at this data, they are using this data. You need to make sure that it's a level playing field as you negotiate with your payers going forward. So unfortunately, the target is not a specific number. I can't give that to you because it doesn't exist. You're compared to your peers, and that will continue to move as other practices get better at doing this also. Right? So how are our practices doing today? Where do I stand in relation to some of the other practices across the country? Share some of the data with you that we got from last week just so you have an idea of what we saw. Right now, about 20% or 1 in 5 of you are actually monitoring HCC codes, that you're tracking that, or have risk-adjusted contracts, right, that are looking at that type of diagnosis information. So some of you are out ahead of others because you've got some experience with this. But the majority of groups out there do not. We did the same webinar for some non-White Plume clients, and the results there were very, very similar. Very, very similar. Okay. Point number 2. It looks like most people, at least the majority, 58%, say that their physicians are doing a pretty good job documenting comorbidities. Right? And for those people, that's really good news. That's really good news. That means we don't have as much physician behavior that needs to change because we know that's not something that most people enjoy. You're doing a good job of documenting comorbidities. But unfortunately, again, less than 20% are actually coding those comorbidities, which is not surprising given that for most people under fee-for-service, coding those comorbidities really doesn't have an impact on your reimbursement today. So that's where most people are today. Think about those things for your practice, where you sit, so that we can start to formulate a plan for going forward. So here's what I would recommend when you think about your plan. If it's going to be a process, right, not a fixed goal, it's something that you're going to have to do several times. We're going to have to work through this process to make sure that you're accurately reflecting patient acuity in your diagnosis coding. And the first step is really education. We're doing part of that today. That's why we're doing these webinars. That's what we want to help you with. Understand what HCC coding is, why it's important, to demystify it a little bit so that you feel like you can move forward successfully. So hopefully we're helping you with that. Once you do your education, then we need to do a little bit of analysis to understand how am I doing at this today, right? I know we don't have a conscious plan in place for it, but you are using HCC codes whether you're aware of it or not. Remember, the payers are automatically mapping those diagnosis codes to the HCC categories. So how am I doing today? Which HCC codes are we using most frequently? Doing some analysis so that you can share that information internally. Once you are armed with that data, then you can start to improve your process, to bring that into your workflow, to make decisions as far as how you're going to handle that, where you're going to handle that. And that's what we're going to spend the majority of our time today, is in that process improvement quadrant. And then once we finish that, we want to review your progress. As the process improvement, the workflow that you put in place, has that been successful? How successful has it been? Where do we still need to make changes, right? And then taking that data, sharing it back with my team internally so that we can do additional education, additional analysis, and make that improvement even better than we did the first time. Okay? So that's the way that we're going to think about it. I'm going to address each of those quadrants briefly, but we're going to spend the majority of our time on process improvement so I can show you some of those specific examples, some practical things that you can put into place. All right, so let's think about education first. All right, when we look at education, the big thing, we're trying to do this with our webinar series. The feedback has been great. The attendance has been great. I hope that it has been helpful for you. We've got the recorded version online from last week's webinar. We'll have this webinar online before the end of the week. So those are available to you, to your teams, to share with colleagues who weren't able to be here, to share with clinical staff, nurses, PAs, physicians. We've got the PowerPoint slides that are available for you. We're happy to walk through those with you if you need some help, because we think this is valuable data to share with those stakeholders internally so that they can really understand, what are we talking about? What is risk-adjusted coding? And why is it important? If they don't understand those two things, it's going to be very, very difficult to operationalize this in your practice. All right, so let me launch a quick poll question about this education. Right, that what do you think your strategy will be going forward? How are you going to handle that? Is that something that you'd love to do, but you just know it's not going to happen? Our doctors aren't going to pay attention to it. We won't be able to do that. Or is that something that you think, maybe I can get them to watch this webinar series. Maybe I can get them to listen to that. Maybe we'll have to spoon feed them, right, one at a time. And we try to come up with an out of the box idea. If there are any groups that say, what we need to have, we'd really love to have you come talk to our doctors about that. We're not making any promises on that, but we're just trying to gauge what people think they will do. So take a minute, lock in your poll answer as far as how you plan to do that education for your physicians. Okay, so once we've done the education piece, or at least started that, we're going to need to do some analysis. And what that analysis says is, how am I doing today? Are we coding these comorbidities? What does that look like? What codes are we using most frequently? So let's take a look. This is something that we looked at last webinar, looking at the diagnosis portion of the HCC coding. Remember, HCC coding, the risk-adjusted coding methodology that's preferred by our government, is demographics plus diagnoses equals your HCC score. The higher your HCC score, the sicker your patients. Right? The sicker your patients, the higher the reimbursement for the Medicare Advantage plans, which is what the HCC was originally developed for in 2004. Obviously, you can see a distinction by specialty. We're trying to isolate the diagnosis coding piece of it. Demographics are what they are. You can't really change that about a patient. But the coding is really different. And so you see, obviously, there are some specialties like oncology, nephrology, endocrinology that are going to be really high. And then you're going to get into the cardiology and then some of the other primary care disciplines. And then some of the other specialties down towards the bottom. Remember, you're not competing, the pediatrician is not competing against the oncologist. This risk adjustment is done compared to your peers. But even when you look at this data, the average HCC by specialty, we can see a wide variety within the same specialty across different practices. This is a listing of 30 different orthopedic practices and what their average HCC per diagnosis is. You can see some of those top practices, the top 10%, right, are all above 0.026. The bottom 10% in this sample are closer to 0.10, right? So we've got about a 3x difference between the bottom 10% and the top 10%. They are all treating very similar conditions. They are all within the same specialty. How do you explain the difference between the best performers and the worst performers? It's probably not their demographics. It's driven by what they code, particularly how they code comorbidities. Even if you drill down to a more specific level and start to look within a practice at different providers, you can see that, again, the top performers are doing 10 times better than the bottom 10% performers. And this is within the exact same practice. But their patient demographic is going to be very, very similar. Right? They're in the same city. They're in the same office space. How do you explain the difference between their average HCC per diagnosis of 0.13, 0.14, and 0.008? Those top providers are doing a better job coding those comorbidities. Right? And where do those values come from? Many of them come from the most frequently used HCC codes. These are the top 10 ICD-10 codes that carry weight under HCC. That may differ from one practice to the next. There are about 9,000 ICD-10 codes that carry weight under HCC. And you can see that some are have more weight than others. Right? So morbid obesity due to excess calories has a higher weight than type 2 diabetes without complication, or even atrial fibrillation. And that's because under the model that Medicare has created for HCC coding, those are the diagnosis codes that seem to have a higher predictive power of future healthcare expenditures for particular Medicare beneficiaries. And I know many of you are not treating diabetes. That's not what you do in your practice. But as long as it's documented, as long as it was present at the time you provided the service, if it's documented, it can be coded. And it's important to make sure that we're accurately coding those comorbidities. And so as you think about some of the analysis that you might want to do, right? Just another quick polling question. Some of you may already be doing this, some of you may not. But for when you think about this and you say, all right, how am I going to analyze what my current state is in HCC coding? How are we doing today? How do you want to do that? Is that something that you're going to do internally? Do you want, is that something you say, you know, we're kind of interested in that, we'll take whatever you can give us. People may want some more granularity, some more detailed reports. If that's something that we're trying to work through right now as far as what is most helpful for our clients. So we can't think of anyone better to ask than our clients to tell us what is it that we can best do to help you in this. So please take just a quick second to answer that poll question. When you think about analyzing your HCC codes, how do you want to do that? What's the best way, or what do you think is the most likely way that your practice will handle that? Okay, we've talked about education. We've talked about analysis. Now I want to really spend some time thinking about how do we improve our processes. what does that look like when I'm trying to accurately reflect patient acuity in my practice? How do I do that? And when we talk to people, and when we ask them, how do you think you'd handle that? Or when we look at groups that have already done this and ask them, what did you do? It typically changes over time. A lot of people make one of the following two mistakes, if not both. So hopefully you can learn from that. The first thing that people think is, you know what, that's something that has to be done by our physicians. That's something that has to be done by our clinical staff, because they're the ones in the exam room with the patient. It's being billed out under them. They're the ones that's ultimately responsible. They're the only ones who know. And the problem with that, aside from the physician change, is that our doctors really need to be focused on patient care. They're the only ones in our practice who can do that. We really need them focused on patient care, and many of them are burned out. There have been a lot of government programs over the last 6, 7, 8 years. Many of those have been seen as administrative burdens by the physicians. You're making me do more paperwork. This is not why I got into medicine. It's not what they're best at. It's not them operating at the top of their degree or at the top of their licensure. I hear often, don't turn me into a coder, right? It takes me too long to go through and do all of these things that I have to do for the government. That's one mistake that we see people make. The other mistake that we see people make is going to the other extreme. They say we can put all of this on coders. We can put all this on our billing staff. Because that's how a lot of hospitals have solved this, right? In the hospital world, your reimbursement is really driven by your DRGs, diagnosis-related groups. That's why they can hire teams of certified coders to read through the physician documentation, which we believe for the most part is very, very good. They can read through that documentation and make sure that the diagnosis codes are coded out to the highest level. That's why Medicare Advantage plans are asking for more and more chart audits, so that they can dig through that documentation and make sure that they've captured all of those HCC codes to maximize their reimbursement. But for the most part, ambulatory physician practices struggle with this. They're not able to do it because they're understaffed. They don't have a big enough team to code every single encounter in a high volume practice from the documentation. Many of them are also undertrained, undercertified. Got great revenue cycle teams. They've got great billers who have a lot of experience, but they don't have enough certified coders who can take the physician's note and turn it in to the rich granular ICD-10 data that the payers are after. You know, at the end of the day, the real struggle here is that there's not a return on investment for that. To staff up, to train up, and be ready to take care of all of that behind the scenes with the reimbursement levels you get from Medicare in your practice today. So how do we handle that? How do we mitigate some of those risks, some of those frustrations? It's by providing a little bit of balance, by taking a blended approach that says, I'm going to try to make this really, really easy for my clinical staff. I can explain to them why this is important. I can get them up to speed on it. And we can do it in a way that doesn't take a lot of their time. And they understand why it's important. And at the same time, I'm not expecting them to be perfect. I can leverage some tools on the back end to help my revenue cycle staff find the places where we have missing data. Make those corrections before it gets into the practice management system and out the door onto a claim where my payer is using that data against me downstream. The most successful practices we've seen take a blended approach rather than trying to put all of that work on their physicians or rather than trying to put all of that work on their billing team. Okay, well that's great and theoretical and high-minded, but where does the rubber meet the road? Let's look at some specific examples of how we've seen people leverage tools and resources to improve their HCC code. All right, example number one. Let's go back to that top 10 list, right? Let's go back and take a look at that top 10 list. You know, if this is one of those things where the 80-20 rule applies. Probably 80% of your HCC value is coming from 20% of your HCC codes. Let's know what they are, right? And then make it easy to capture those. So a couple of different ways that we've seen groups do that. Number one, here in Capture, what one client did, they designed their electronic super bill. It looks a lot like everybody else's, right? But if you'll notice on the far left-hand side of this screen, what you see, the top corner right here is a miscellaneous section. And then the last line in that section says comorbidities. Now, what they've done here is built a custom scenario so that when I click on comorbidities, I get this pop-up list. And it's got my top 10 HCC codes right there for me. I can select one, I can select none, I can select three. But it makes it very easy for me to remember to do that. It makes it easy for me to capture that. And as a little bonus, what I really like about this example is that they put the HCC value right there in the custom scenario. So that's a reminder for me that says, you know what? There's a difference between diabetes with and without complications. There's a difference there in my HCC value. But if you look at AFib, for example, all three of those have the same weight. So I think it's a helpful tool or a helpful way to deploy that through a custom scenario. Now, very similar concept, exact same thing, exact same top 10 list, done a little bit differently. Take a look at this one. And what we did here was actually made a modification to their form. Rather than putting that behind a custom scenario, they listed those top 10 HCC codes right there in their own section labeled comorbidities. Again, they included the HCC values there, right there on the line item to make that easy for the clinical staff to know the difference. Really two sides of the same coin. I think they're both great ideas. I think you can handle that either way and be successful. And there's some flexibility if you're so inclined that you could do both of those solutions within the same practice. I've even seen another group, I don't have the example here with me today, but they designed their own HCC tab right there in Capture, so that they've got all of those codes grouped by system on one tab. Very creative way to try to make this easy for their doctors. All right, that's one example. Let's look at another. All right, example number two. not all HCC codes have the same weight. Okay, so take a look at this one. This family of codes, E11, each of them has an HCC weight. It's like that my kids watch Sesame Street. One of these things is not like the other, right? The one that's different from all of the others is type 2 diabetes without complications. Even if you use an unspecified code that says we know that there are complications but we don't know what they are, that still carries a higher value than type 2 diabetes without complications. Right? So how have I seen clients make sure that they're using the right HCC codes? Well, let me show you one way, a creative approach that one client took in ExceloSmart. What they did here is you've got a patient encounter, level 4 office visit. We've got a diagnosis of E11.9, right? That's type 2 diabetes without complications. But if you look at the secondary diagnosis on this encounter, I12.9, that's chronic kidney disease. So they built a rule that says when I have this combination of codes, it's a custom rule, when I have this combination of codes, I want you to stop my ExceloSmart user. I want you to stop my biller. I want you to stop my coder so that they can review the documentation. Right? Because we use uncomplicated diagnoses of diabetes, but if that chronic kidney disease is a result of the diabetes, we need to change that primary diagnosis. We need to change it away from 11.9 to E11.21 or .22 or .29 to make sure that we're accurately reflecting our patient acuity. Right? It's a way that I can leverage this tool behind the scenes to help make this easier for my clinical staff and to make sure we're coding out at the highest HCC level that we can. We want to accurately reflect how sick our patients are so that our risk adjustment will be done correctly, so that our quality measures will be done correctly, and so our resource use calculations will be done correctly. Okay, let's look at one more example. And this one's the most complicated, but it's really, really cool. It's really, really cool. So we are looking at some more in-depth analysis here. We're doing some provider-specific analysis within a practice and doing some comorbidity regression analysis. Okay, so let me explain that. Within a practice, let's make it really simple and look at just 2 doctors within a larger practice. Doctor 1 is in the top 25%. Not the best, but he's in the top 25%. Doctor 2 is in the bottom 25%. Again, not the worst. You know, we're talking about 2 ends of the middle 50% here for the practice. But you can see there's a significant difference in their HCC per diagnosis. Does that mean that provider 1's patients are nearly twice as sick as Doctor 2's patients? Right? By now, you probably know or have the instinct to know that's not true. It's not that. The difference is in how they code. So let's get very specific here. Okay, 2 doctors within the same practice. Let's look at what happens when you control for the primary diagnosis on the encounter. So when provider 1 sees patients with a primary diagnosis of hypertension, on nearly 1 out of every 3 of those encounters, that doctor codes other comorbidities that have a significant HCC weight. That's higher than the practice average. When provider 2 sees similar patients with the exact same primary diagnosis, he only codes those HCC comorbidities 1 out of every 20. Do you think the patients that they see are that different? Same practice, same location, same primary diagnosis code. Vastly different HCC coding. The difference is how they code. So let's drill down underneath that and look at what those most commonly used HCC codes that are the comorbidities of the hypertension diagnosis, what are they for this particular group? And you can see some of these were on my top 10 list before, right? That's because there are only a certain number of HCC codes available in the universe. And, you know, for example, you look at morbid obesity, right? That is true across the country, right? Right now, I believe the most recent data on it is 6.3% of the United States population has a BMI of greater than 40. That would be a diagnosis of morbid obesity. Right, so you're going to see that pop up frequently. The real question is, are you coding that accurately? Right? So how do you operationalize this? How do you incorporate this into your workflow? Let me show you how it works. So here I am in Excelicapture. You can see on the third column about most of the way down, there's that hypertension code. Right? So today what probably happens for most of you is you click on that and it's got your ICD-10 code right there for you, very, very fast, very, very easy. Problem is, we did not code any of those other comorbidities unless you went and clicked on them in other places on your form. So how do we make that easier for our doctors? Right? What are we gonna do with that? Well, let me show you a couple of different options. All right, let's start over. And this time, when I click on hypertension, look what I've got in my custom scenario. I've got the primary diagnosis up there at the top, but I also have my most likely comorbidities that go along with that particular primary diagnosis listed right there below, so that I can select just the primary diagnosis if they don't have any of the other HCC codes. I could obviously make this longer or shorter, depending on my primary diagnosis, depending on how I want to treat it. Right? But I can make those selections. Makes it very, very easy for my clinical staff, whether it's my doctors, my nurses, my PAs, maybe my scribes that are helping us with this in Excelicapture. So that's one way to handle it there. Let me show you another way. If you'll notice, the thing that's different here when we start over, I still have my hypertension there, but next to it, I've got a little HCC box. What that allows me to do is select my hypertension diagnosis, and then if I want to go in and click on that HCC box, I'll get those common comorbidities that have that HCC weight, again, to make it easy for me to select those. There's a lot of flexibility of what you can do here, but the goal is to make that very, very easy for our clinical staff. Now, on the back end, I can also make sure that we've built into ExceloSmart some tools to try to make that easy for me as well. So here's a rule that says I see that diagnosis with a primary diagnosis code of hypertension, but we didn't code any of the comorbidities. I know from my analysis that I should expect 30% of our patients, at least 30% of our patients, to have one of those HCC comorbidity codes. So that's worth my investment of my billing staff, of my coding staff's time to stop and to review the documentation on this. I can list out for them some of those most likely comorbidities so that they can be on the lookout for that and that they've got the code right there for them. Now, another trick that a lot of people may not know about yet is I can actually right-click on diagnosis codes here in ExcellaSmart and use those same custom scenarios. I can even build some of those custom scenarios based on ICD-10 codes. So watch this. If I right-click on I-10 up in the diagnosis section, if they show me my custom scenario, it can pop up that same custom scenario that we saw in Excella Capture. Again, that makes it just another way for me to select the right codes, just trying to make it easy for my billing staff to do this correctly and to do it quickly. Make those selections. You see them come in as additional diagnoses, in this case diagnosis 2 and 3. Just a reminder, you would want to make sure that they're all linked to that office visit as well. Okay, so when you think about this, let me ask this last poll question, basically saying if you had the right tools, how do you think your practice is going to handle this? Do you think you'd try to get your doctors to do most of this, your clinical staff to do most of this? Will you try to put the majority of this work, do you think that they'll try to put the majority of this work on the revenue cycle team? Will you have some sort of blended approach? Or, you know, maybe despite all of our best efforts and all of the training that you're going to do for your clinical staff, there's probably not going to be much change. That's okay too. We're just trying to figure out where we think people are, what you think you'll do, and that helps us be more helpful to you to try to make sure that we're providing you with the right solutions that you need. Okay, so you want to make sure that you can operationalize this in your practice. Okay, now, so we've talked about education. We talked about analysis, how to look at what you're doing today, how you're doing it. And then I wanted to spend the majority of our time on that process improvement part. I think that's where the rubber meets the road for your practice, right? And then at the end, you want to review your progress. And that's really kind of going back to that analysis part and saying, here's where we were before. How are we doing now? Which of my providers have we gotten a little bit better? Which ones still need work? Are the top 10 HCC codes that we used to use the same that we're using now? Or has that changed a little bit now that we've improved our processes? Right? And then that progress review turns me right back to education so I can share that information with my billing team, with my coding team, with my clinical team, with my doctors, so that they can see the amount of progress that we've made, and then we can continue to make the necessary adjustments. Because the goal for risk-adjusted coding is not to get to a certain number. It's to make sure that you're accurately reflecting what your patients look like, so that you make sure that your quality scores, that your cost scores are done correctly. So what are the takeaways from today? Let me walk through this for you, and then I'll try to answer as many questions as we can in the last 5 minutes or so. Diagnosis coding is changing again. Remember, it's changing again. We went through that big change from ICD-9 to ICD-10. But we've got 2 big changes in our future. One, October 1st, we're going to have to be more specific in our diagnosis coding. The majority of you are doing a great job at that. But number 2 is accurately coding comorbidities is going to be very important for accurate risk adjustment. Many of you are just starting on that, and we want to do everything that we can to help you successfully transition to this value-based world, just like we helped you successfully transition from ICD-9 to ICD-10. Patient acuity or risk-adjusted scores are going to matter in setting the appropriate targets for the quality measures and the resource use scores under MIPS. Those scores are going to be measured against your peers, right? So you don't have to outrun the bear, you just have to outrun your friend, right? Our goal with risk-adjusted coding is not a specific number. It's that we're always getting better and getting closer to completely, accurately reflecting what our patients look like. To get there, you need to educate your team, billing team, revenue cycle team, coding team, clinical team, physicians. Assess where you are today so that you can make those types of improvements in your process. And then let's follow up and see how well those adjustments impacted your risk-adjusted coding scores. You've got some good existing tools to do this. The custom scenarios that are available in Excelicapture and Excelimobile and Excelismart are very valuable. The forms design, the analysis is helpful. Building custom rules in Excelismart. All of these things can try to make this as easy and as painless for your doctors as possible, and that's the goal. We don't want to slow them down. We don't want to turn them into coders. But we also want to give the billing and coding teams the tools that they need to be successful. I know I went through a lot of information. I know I went through it quickly. But we have recorded the webinar. We've shared the PowerPoint slides. If you need copies of either of those, let us know. We'll make sure that we get those to you. This is something that you can be successful with that doesn't have to be impossible. Let us help you where you need help. Let us know where we can best help you. Thank you for attending today. A quick reminder, the 4-question survey is very, very helpful for us in making this webinar better going forward. So please take the 30 seconds at the end of the webinar to fill that out. You'll also get a reminder for that in the follow-up email that goes out after the webinar. But thank you for your time. I'm going to turn it over to Shelley to try to handle as many questions and answers as we can.